Hey, thanks so much for joining us today. We're going to go ahead and start. Thanks for joining us for Georgia MemoryNet Insights. It's Dr. Gabriela Cohen today, and she is our course director and a great speaker, so you're in for a treat today. Dr. Cohen, I'm going to turn it over to you, and I'll stand by and monitor your chat and help you out in any way I can. Thanks.
Excellent. Thank you. Thank you so much, Ted. Hi, welcome, everybody. Thank you for the warm introduction. So today, we're going to talk about how to interpret a cognitive assessment, the kind of cognitive assessment that we do here in Georgia MemoryNet. And we're going to present a case so I can show you what the report of a cognitive assessment looks like. I have no conflict of interest, and I'm not a neuropsychologist. I'm a memory provider, I'm a memory expert, and I've been trying to interpret this cognitive assessment for a long time, so I will try to share my experience, but I'm not a neuropsychologist. Good. So what is a full cognitive assessment? So basically, we have basic description. That's our objectives. We want to know what are the cognitive domains tested in a cognitive assessment, how to interpret this, and how it helps you narrow down the differential diagnosis when you have a patient in front of you. So how we diagnose dementia? And I think we discussed this in previous lectures, but basically you have to interview a patient and a relative member who really knows the patient well. We want to know exactly how the patient is doing the activities of daily living. You want to do a focused physical exam on cognitive disorders. Of course, you want to test cognition, and you're going to do screening and confirmatory tests. And you want to rule out secondary causes that could mimic dementia, and they are not cognitive disorders. So if this is the initial assessment, imagine that you have a patient for the first time at a memory clinic. So you're going to start with a screening test. And the screening test could be a mini-cog, could be a SLAMS, could be a MOCA, could be a mini-mental, or could also be a function assessment. And once you have a positive screening test, you want to do a confirmatory test. And this is what we're going to be discussing today. And we call this a full neurocognitive assessment. So basically, in a full neurocognitive assessment, you want to assess all cognitive domains. So you're going to include tests for attention, executive function, language, memory, and visual spatial skills. If you start with a screening test, and imagine that you see the patient in Georgia MemoryNet, and you do a screening test like a MOCA, the Montreal examination, and the result is really low, and you suspect that your patient has moderate to severe dementia, and a MOCA is 12 or below, you could really stop there. But if you have a higher MOCA and you want to nail down the differential, you're going to try to do a full neurocognitive or neuropsychological assessment. And I like to call this neurocognitive and not neuropsychological, because we're really focusing on all cognitive domains. Much more, you're not doing like a personality disorder examination, you're really focused on cognition. So this is the MOCA. And I'm sure that most of you are familiar, but basically it's a test that the maximum score is 30, and you really test all cognitive domains. You do the first arrow here, you really do, this is part of the trial-making B. Here, you ask the patient to link number 1 with letter A, number 2 with letter B, and you alternate a number and a letter, and we're going to see a little bit about more later. You ask them to copy a cube, and you ask them to do the clock. So here you're really testing visual spatial skills, and with the trial-making B, and with the clock, you're also testing a little bit of executive function. Then you do a nomination test. So you show these 3 animals, and you ask them to nominate. And some patients have difficulty with rhino and camel because they are not animals that we see every day. Then we ask the patients to learn 5 words, and we don't score for immediate recall. Then we distract them doing an attention test. This is called the digit span. So we ask the patients, we say numbers, and we ask the patient to repeat numbers, first forward and then in reverse. Then you do another attention test with the letter A. Then you do a little bit of calculation. You continue to do a little more of language. You test how the patients are able to repeat, and you do a fluency test. And this is called a phonological fluency test, where you ask the patients to say as many words as they could with the letter F in 1 minute, and you record that. And then you go back to delayed recall. You didn't really score for immediate recall, but you go back to delayed recall of those 5 words that they learned, and you see how much they remember. And you finish the test with 6 points for orientation. So this is basically the MOCA. So it's a good screening test because you're really trying to capture memory disorders, also a little bit of executive disorders, a little bit of language disorders, and there is also another very quick screen test for frontal dysfunction, where you see here the obstructions, where you ask the patient in which way a banana and an orange look like. This is really for frontal disorders. Okay, so you start with the MOCA. Of course, you corrected the score of the MOCA by age at the level of education, and then you do this structured interview that lasts usually an hour. And ideally, we want to include a functional assessment and a staging into that assessment. And you want to include some kind of test to screen for depression, anxiety, and sometimes we also include some tests to check for behavioral symptoms in dementia. So this is the protocol that we do at Cohen, and I think it's interesting that you are a little familiar with this. So when you refer a patient to us and you see the report, you know what does it, at least the names of the tests that we're doing. So for memory, we're doing the Ray learning test, and I'm going to explain what this is. For visual spatial and for memory, we're doing the Ray complex figure. We ask the patient to copy and then to remember a very complex figure. For denomination, we do the MINT. We show them a series of pictures and we ask them to nominate with the right word. For fluency of the language, we do both. We do a semantic fluency test where we ask the patients to say as many animals in one semantic category in 1 minute. And we also do the phonological language fluency test, for example, asking them to say words with a letter. Then we do the Tremerkin A and B, and I'm going to show you what it looks like. Then we test for attention using the DigiSpans. And finally, we do some more tests for visual spatial. So it's a very complete workup. We're really testing all these cognitive domains that you see here on the right, okay? So this is for me, this is one of the most interesting tests, and it gives us so much information, is the Ray auditory verbal learning test. So what you do? The tester reads 5 times these 15 words. So you read the 15 words and you ask the patient, after you read them immediately, you ask them, okay, how many words do you remember? And in this case, from these 15, in the first trial, the patient remembers 6. I read again the same 15 words and I see how many he remembers. Second trial, he remembers 6. Third trial, he remembers 6. The fourth trial and the fifth trial, he remembers 7. So you could see that there is not a lot of learning curve because he's really kind of stuck between 6 or 7, which is not bad, but it's not perfect. Then what you do, you distract them with a different set of tests of words. And then after 30 minutes, and this is the most important piece of information, you ask them, okay, from those 15 words that you learn, how many do you remember? In this case, the patient learned 7 words, but after 30 minutes, he only remembered 1. So definitely we could see that this patient is amnestic because his verbal memory is decreased, okay? And I don't know, Ted, if there are questions, so we can keep on going.
You're doing great. I'm putting some information in the chat about where you could find more about the different resources that you're talking about. So
excellent. And if there are questions, please reach out because we want to do this very interactive. The second test I want to show you, this is called the Ray complex figure. So this is a very complex figure you could see here on the left. And first you ask the patient to copy exactly this figure and then you score for this, okay? And then you ask the patient to see, you turn off the patient and you say, okay, of the picture you just copied, what do you remember? And this is the immediate recall. And then after some time, we ask the patient again on delayed recall. And this gives us a lot of information of visual memory. It's particularly important in patients who have aphasia and who maybe you cannot test the memory using words. So this is an excellent visual spatial and visual memory test. I like it a lot and it gives you a lot of information. Third, you do the fluency test that I just described, and this is kind of interesting. So when you're asking the patients to say words with the letter F, you're really focusing on the frontal lobe function. And when you ask the patients to say words within a category, and we call this semantic test, it could be animals or vegetables, you're really checking more for temporal lobe, okay? So sometimes you will see the pattern. If a patient has Alzheimer's, maybe he will do much better on the fluency test than on the semantic test. The opposite, if the patient has depression or frontal dysfunction or vascular lesions, he will do much better on the semantic than on the phonological. That's why this gives us a lot of information. So it's really interesting to try to go into details. This is the trial making A. So you present the patient with this page, with all these numbers, and this is a time test. So you ask the patient to go from number 1 to number 2 to number 3, and you see how much time it takes them. So what is normal is really to do this in less than 29 seconds. So this is a very good test for visual spatial and for attention, okay? And this is a little more complex. This is the trial making B. And if you remember the MOCA, at the first row on the MOCA, we have like a smaller trial making B. So here is much harder. So we ask them to alternate from a number to a letter. So number 1 with letter A, number 2 with letter B, and so on. And here you're checking visual spatial, but you're also checking for executive because you had to alternate one number and one letter. So the normal result for this is 78 seconds or less, and you see this very early impair in dementia and cognitive disorders. It's a very good test.
Going back to trails making B for a second, is there a certain point that you just stop because they're not going to finish?
Yeah,
ever?
usually if it takes more than 3 minutes, you could really stop it. Okay?
Thanks.
And then I didn't put the whole cognitive assessment, but then you include an attention test, and this is called the digit spans. So you say a series of numbers, for example, 257, and the patient has to repeat 257. So if the patient is doing okay with 3 ciphers, you keep on going and you see how focused and how attentive the patient is. After you're doing that, you do the same digit span, but in reverse order, which is much harder. And of course, all these tests have normal values, so we know how to compare. And then you do the Benson line test, which is really a visual spatial test. So you could include other tests. So now that I gave you like a very quick, and I'm not pretending to teach how to do a full cognitive assessment in 10 minutes, but at least I want you to be familiar with the names of the tests. I will show you a real case so you could see how we report it, okay? So this is a 73-year-old guy who comes to my clinic. I'm a short-term memory net provider. The main complaint is that the patient has short-term memory deficit that started about 2 years ago. There is a small slight progression in the last year with some more memory problems. The patient is repetitive in the interview. He knows and he's very organized. He started to use calendars and reminders so he wouldn't make any mistakes. He uses also shopping lists because when he goes to the grocery store, if he doesn't have a shopping list, he doesn't remember what he's supposed to be buying. He drives without problems, and the functional assessment using all those tips and skills, the calendars, the reminders, the shopping list, the patient is absolutely independent in all basics and instrumental activities of daily living. Past medical history, hypertension, type 2 diabetes, well controlled. There is no family history of dementia. The patient has a 12, and this is very important. All these tests have to be adapted due to cultural level and literacy level. So of course, I'm not going to interpret a MOCA in someone who maybe is illiterate or who has less than 5 years of education. So we always pay a lot of attention in getting a good educational level history. So no other past medical history. I do a physical exam, and basically everything is normal. The patient is alerted and oriented. And I screen, in this case, with a minicog. And I think we have a few lectures on the minicog, but basically the patient was able to draw the clock okay, to put the right time. But on delay recall, he only remembered 2 of 3 words. So of course, I'm going to want to do in this case, I suspect the patient could have mild cognitive impairment, so I want to do a full cognitive assessment. So this is his mock-up. So the little sample of the trial making B, he did okay. The cube, he did it okay. The clock, he actually didn't do it okay. He had problems, so he lost 2 points here. The denomination of the three animals, he did it okay. Immediate recall, we don't score for that. Then we did a little bit of dish span, the little bit of dish span that is included on the MOCA, and the attention was okay. The letter A was okay. The calculations was okay. Then we did the language test, the abstraction, and what is very interesting in this MOCA is on delayed recall, he really remembers 0 of the 5 words that he learned. So overall, his MOCA is 23. And it's interesting, I always try to see which cognitive domains on the MOCA are affected. And I could see here that definitely short-term memory is definitely affected. So this is a case that I would like to have a full cognitive assessment.
Hey, Dr. Cohen, if you could go back for just 1 second.
Yes.
Do you take off hippo when it's the rhino? Is that
No.
that error there,
No.
do you think?
No, if they say hippo, then they lost 1 point. Yeah, I'm very strict.
Thank you.
So we do the Ray learning verbal test. So in this case, remember, this is a test where we read 5 times 15 words without, this is really memory out of context, just poor memory. Remember a list of words. There's nothing harder than that. So in this case, first trial, 5, 5, 2, 4, and 0. So there's not really a learning curve. He's not learning anything, and he's really low. Remember only, so when you see the report, you're going to see all these numbers added. So he actually got 16, which is pretty low. We distracted him with the list B, and after 30 minutes, A7, he remembers 0. So he learned 16 in 5 trials, and he remembers 0. So he's definitely short-term memory is very impaired, okay? So this is the copy of the figure. So you could see when he had the figure in front, he copied it really nice. But when I turn at the page and I ask how much he remembered, immediate, like 1 minute after, sorry, this is the delay, he really remembered not a lot. And I didn't put the picture of the immediate recall, but it was really bad too. So this is the denomination test where we show them a series of images, and we usually use 32. So he struggled with the last ones, and you could see there is a progression. Maybe it's too small, but the first picture we show is a butterfly, which is a very easy word to remember, but the last words are really harder. So it was kind of so-so, not very bad, but not perfect, okay? So this is the fluency test, the phonological fluency test with the letter L, and he got 14, which is not bad, but it's not great. And this is the animals, and he got 16. So overall, language fluency is not bad.
He's just saying those out loud, and the person, someone else is recording those, correct?
Yeah, so what you do is you ask him, okay, in 1 minute, tell me words that start with L, and you record that. And it's interesting that you record that because sometimes the patients are very repetitive, and then it's something that we would like to know if they repeat the same one. This is a trial making A on the left. You could see he had no errors. Again, this is for visual spatial and for attention, but it took him almost 1 minute. And we say that the cutoff point is 30 seconds or less. So he was a little late. And this is a trial making B. And it actually took him a long time, and he struggled with that too. This is the digit span that I was saying before. Attention overall is very good. He could reach arrow 5 on the forward and arrow 4 or 5 on the backward. So attention is very good, okay? So this is kind of the output. If you're seeing a patient for Shearman, you will see that we put this under review, under media. So this is the summary. So he got a mock-up 23. Anything that is below 5% corresponds to -2 standard deviation, and is definitely abnormal. So when you analyze this, you really want to look for numbers on the percentile, because this is compared to age and educational level and sex below 5%. So we said that anything below 5% is abnormal, okay? So overall MOCA 23, executive overall, even though it was a little prolonged, is still not below 5%. Visual spatial is not below 5%. So when you reach to memory, What is really abnormal in this output is that definitely the braille learning test was very low. He learned very few words. Remember, we say 16, and he couldn't remember anyone. So definitely the memory domain in this cognitive assessment is very impaired. And the language in this one, the mean was also low. So overall, when you see this pipe, you are going to see this is kind of how we present. So anything that reached the outer circle, that corresponds to -2 standard deviation. So in this case, his memory was definitely impaired. It was both verbal and visual memory, and the language was a little involved too, okay? So this is the MRI of my patient. We have still a few minutes. So you could see the sagittal, there is some mild parietal atrophy. You could see the axial, there are no, this is the T2, there are no vascular lesions. And you could see the coronal will really focus on the hippocampus, and he really had mild hippocampal atrophy. So based on his symptoms and of the cognitive assessment, my diagnosis is the patient has minimal cognitive impairment because he was below 2 standard deviation on at least one cognitive test. The memory was involved, so I call this amnestic. And the plus is because other cognitive domain was also involved. Remember the fluency, the denomination. So his clinical diagnosis is amnestic plus MCI. Okay? And this is basically the curve. We want to see if the patient has normal aging versus MCI versus dementia. And just a reminder that the limit and the threshold here between what is MCI and what is dementia is the functional assessment. And we say at the beginning that this patient functional assessment was really normal. That's why my diagnosis is MCI, okay? So going back to the chart of MCI, the patient has memory impairment, yes. So I call this amnestic MCI. There are other cognitive domains affected, yes. So we call this amnestic plus or multi-domain amnestic MCI. So in this case in particular, I wanted to have biomarkers because I really want to answer this question. Does the patient MCI, is MCI in this patient due to Alzheimer's disease pathophysiology? So in this case, we did a CSF tab and we analyzed for the proteins that are abnormally accumulated in Alzheimer's disease. So the results of the CSF showed that he had accumulation of beta amyloid in his brain and that he has high tau and high phosphotau. So after having the CSF results, I could say that in this case, the patient has amnestic plus MCI due to Alzheimer's disease. Another big word for this is a prodromal Alzheimer's disease. So this is my patient, and we have at least 6 minutes for questions. Thank you so much for listening.
That was super. I really enjoyed that. That was great. When you think about either preparing this talk or early in your training, what were some of the tests that you kind of go back to? And obviously it's an array and a battery of tests, but are there certain tests that you go back to and you say, wow, I really want to check this test out in this patient? How do you do that? How do you figure out this is the most important test in a given patient?
That's a good question. So you interview the patient and you really have an idea or at least a suspicion of what cognitive domains are involved. So based on that, this is kind of the protocol that we have at GMN, and we do this for everyone. But many times, if you're talking to a patient and you suspect that maybe the patient has frontotemporal dementia, or maybe the patient has anaphasia, or maybe the patient has an atypical form of Alzheimer's, like an executive form, or posterior cortical atrophy, you want to include more tests. But this is like the bread and butter. With this, at least you have you're really testing each domain. Sometimes you want to include more tests I also like a test called logical memory, where you test the memory within a little story, and that gives you sometimes more information. But I think that with this protocol is pretty, I think it's good. It's good because it gives you an idea of which cognitive domains are really affected. Sometimes I do some more tests, but
that sounds great. We have a question from Dr. Kolshrestha.
Yes.
And so I'll have him come off and ask it.
Hi, Dr. Cohen. This was a terrific talk and a very good refresher on some of the topics. I wanted to ask you, when adults struggle with attention issues, and some of them have undiagnosed ADHD, or a lot of them are anxiety, depression, but you're kind of not sure if it's fully in remission or not. Would that be something take into account while administering these tests?
Yeah, of course. Always,
like attention.
Yeah, the person who is doing the test is also observing, but definitely there is this, when patients who have depression and anxiety, you usually see that the attention domains are more affected. And of course, if the patient has apathy or is really difficult for him to concentrate, of course, he won't do well on the learning curve either, because the first step to remember something is to pay attention and to incorporate that. So you have to have a general idea of what's going on. Sometimes, for example, if I see a patient who has melancholic depression and I do a cognitive assessment and they do really bad, what I do is treat the patient and recheck. So this is usually like a journey. You could repeat some of these tests if you're not sure. You want to be sure when you give a diagnosis of memory, dementia, MCI, that there are not other secondary causes. So that's why you want to include all these attention tests to have an idea of which cognitive domains are more affected. I don't know if I answered.
Yeah, I was just saying that when you document, you could say that maybe that day testing could have been affected by these other medical conditions.
Definitely. And
the patient has.
It's also very common that we have patients here, for example, already with untreated sleep apnea. So you do the cognitive assessment and it's very bad, and you ask them how they sleep, and you don't want to jump into any conclusion. You really want to, in that case, with a patient with sleep apneas, you want to give him a CPAP and recheck. So sometimes we don't want to rush into this. So you need to rule out all these different secondary causes. But definitely depression, anxiety, it's a big one.
Big one, yes.
Dr.
Thank you
Cohen,
very much.
Thanks, Dr. K. Hey, Dr. Cohen, there are a couple of other questions and comments in the chat. One of the questions was, how long does it take to do this battery? And do primary care providers do this very often? Do they refer this type of thing? So why don't you take those two questions? Thanks.
So usually in primary care, when you suspect there is a cognitive disorder, and especially if you suspect early MCI or early dementia, you don't have time to do this full cognitive assessment, and you also don't have the skills and you're not certified. So this full cognitive assessment, at least it takes an hour. But for example, yesterday I saw a patient who I just diagnosed with Lewy body disease, and he was very, very slow. And it took us 2.5 hours to do the full test. So you don't have time. So I think what you should do is screen. And if you think that this is something significant, you could refer the patient to us. We do a full cognitive assessment, and then we provide a diagnosis and we refer the patient back to you. And at least you documented how all cognitive domains were in that time. And I think it's very useful.
There's a comment about so you have a memory, you have a cognitive geriatric hat on, that you do a lot of your work with the memory assessment clinic at Georgia MemoryNet at Grady in Atlanta. When you are doing your normal geriatric clinic, what are your go-to tests that you're doing? You talked about some of them at the beginning. You talked about the MoCA. You talked about
I usually, when I see
Minicog.
For the first time in geriatrics, I want to do a geriatric assessment, and I want to test cognition in everyone. So in my experience, I talk to the patient. Of course, I always ask about memory, and I do at least a Minicog and a very detailed functional assessment. So in geriatrics, the money is on the functional assessment. So I spend 5-10 minutes on the functional assessment and the Minicog. If I suspect something else, I want to spend more time with this patient. I really refer them to GMN, so they could have a full cognitive testing. If I see a patient with moderate to severe dementia and I do a cognitive test in clinic in geriatrics and the patient is very impaired, maybe that patient doesn't need a full assessment, or sometimes I still do it because I want to be able to document at least one in this patient's life what the cognitive tests were. So, but definitely mini-cog, and if I would be screening with MOCA here in the geriatric clinic at Grady, I would have so many false positives because the cutoff point is usually 23. All my patients in geriatric really depends on literacy level, cultural level. In geriatrics, probably 60% of the patients without MCI, without the dementia, will have a positive MOCA. So I don't want to screen with such a test with all these false positive results. Definitely not.
Got it. Hey, Dr. Cohen, is the last slide in your presentation the evaluation slide, or is this no, I'm sorry, at the very end for attendees to evaluate the presentation?
I'm sorry. Yes. Oops. Sorry. We need to put the.
Yeah, no worries. I'll see if I can find a copy of it. One thing more, if you, yeah, we'll send it. If you registered, we'll send out the link. Sorry about that, not having it. Dr. Birju Patel put in a number of great comments. I maybe want to go back to his first comment, which is Trails Making B and maybe even Trails Making A for kind of standalone tests for driver's assessment.
Yeah, that's a great comment. That's a very good test for attention, executive function. In some driving evaluations, they want to include that. That's a great comment. Yeah, it's a great test.
Hey, thanks so much for joining us today at GM Insights. Dr. Cohen, that was awesome. Really appreciate you. And thanks for everybody joining us. And I did put in earlier that if you missed the first part of this talk, or if you've missed any other talks that we've given in the past, we have a YouTube channel and you can go and catch up on what you missed. I'll put this back in as the last chat. And so thanks again for joining us. And if you want to see more of this content, come and join us in the future, but you can also look at past episodes. So thanks so much.
Excellent. And I'm
hey,
so sorry
have a great day.
I didn't put the feedback, but
no, that's okay. Don't worry about that. We'll get it out to folks. All right. Appreciate everybody. Thanks again.
Thank you. Bye-bye.
Bye. Oh, we did just put the link in the chat in case you're still on and want to evaluate. Thanks so much.